Hello and welcome. Hello officially. My name is Emma Cooper and we are hopefully going live on YouTube, Facebook, and Zoom. This is Three Things. This is the chat interview show presented by the Tyee. And I'm very, very excited to be talking with our health reporter, Moira Wyton, who I'll introduce in just a second. Three Things is a really, really informal conversation. We're going to be talking about health today, and we're doing that from the unceded territory of the Musqueam, Squamish, and the Tsleil-Waututh First Nations. And again, this is not going to be the definitive answer on in terms of health, but this is a conversation with the folks in the Tyee family that I'm really, really happy to be part of as the outreach manager here at the Tyee. And Moira Wyton is in an interesting position. She came on to the Tyee as an early career journalist, and she was working with us for about a week, and then the pandemic hit, and then she's reporting on it. So she's got a lot of experience in terms of she's a graduate of UBC. She's worked with the UBC bonus points if you can find their swag in the background when she jumps on the live stream, and she was at the Edmonton Journal prior to joining us. So please give a warm online welcome to Moira Wyton, everyone. Ta-da. Oh, there we go.
Hi, Emma.
We're doing it. We're live streaming, and that was a glorious entrance.
Thank you.
Excellent. So could you just, before we even get started, just tell me what it was like to start reporting on the biggest health story in memory and kind of getting a new job going all at the same time?
Oh yeah, so easy, just a walk in the park. No, I mean, I was so excited when I was offered the role and got to join, and honing a beat is such a coveted thing, like getting to really go deep and meet the players and the movers and shakers in an area is just like, I'm just so lucky to get to do that. And I think I was a little bit initially very nervous because, there aren't that many working dedicated health journalists in Canada. So I was kind of realizing I had to chart my own path. Right. And of course I am, but now that we're all essentially health reporters, I kind of feel like I get to watch what everyone else is doing and kind of learn. We're all learning, I think, to a degree, about how to report on this pandemic. And I don't really know if I'll ever be a health reporter where the pandemic isn't kind of the lead. I think that'll take a while. So yeah, no, I'm happy to be learning, seeing so many publications take up different niches. The Atlantic is doing really good big picture stuff. Then we've got people on how this is affecting the environment, at our friends at the Narwhal, or stuff like that. So I really am getting to kind of find the stories that I want to tell, because I can rest assured that the rest is getting covered too.
Well, that's nice for you to put it in the context like that, in terms of just yeah, it's really a team effort, and I know you've said that. It's a lot of folks in the Tyee are reporting on the pandemic from different angles. Do we want to do a little show and tell item before we get going, or?
Sure. Sorry, I totally forgot to grab it.
That's okay.
This is my camera. It's a Canon Elan 2, and my grandparents gave it to me. They bought it. It's like a 1999 or 2000 model. I haven't been able to find the exact year, but it's within the last two generations that Canon was actually making film photos. I think, Emma, you had a good joke about it kind of being the last and an obsolete range of technologies. But I don't know, I really love it, and it's broken right now, but I've shot some nice film on it, and I'm excited to get it working again. So,
yeah, and it'll be a process to figure out how that happens, which definitely is a good segue into talking about the healthcare system, like you said.
Definitely.
And your general topic today was how the pandemic is actually improving health reporting. And you've alluded to the fact that so many different organizations and people are now focusing in on health with their different lenses, and that's a great thing. what would be another thing that you see that has been a really big change and that is sort of because of the pandemic, how health reporting is sort of moving forward and improving?
Mm-hmm. You know, health reporting, I think people are realizing now, just with like how far-reaching the pandemic and precautions against it are affecting our lives, just how much health is not only about hospitals and what you do when you get sick, but it really is like, I like to call it, or I do call it, the cellular level of politics. Like health is so political, and the social determinants and structural determinants, I've heard them called both, but I think both are valid terms of health, are like really being exacerbated and amplified and with like a lot of urgency. And I think, you know, maybe health reporting, and the health reporting I have done has been, prior to being at the Tyee, has been very focused on like new hospitals opening, you know, transplant policy. I did a lot of reporting on that in Edmonton and across Alberta. But there's so many more things that determine your health, more so than, you know, how close you live to a hospital. It's, are you well housed? Do you have good income? What's your employment or immigration status? Are you a refugee here? Do you have a disability? Are you a queer or trans person? Are you racialized? Are you Indigenous? You know, I think people are really starting to question that like utopia of healthcare system in Canada that we like to talk about, and kind of yeah, kind of questioning more who actually gets that, especially as we see like mental health come into the limelight with the pandemic and isolation, and like long-term care and assisted living really being hit so hard. You know, people are really, I think it's all these like more like hidden aspects of health are like coming to the surface, and it makes it easier to report on them in a way that people get.
Right.
Mm-hmm.
So maybe some people feel like we had a better system when not everyone was coming forward with their legitimate issues and it was doing great. And now we're hearing that that's not been serving everyone. So definitely. And it's very cool to see that the health coverage you're doing is helping kind of open up that conversation more broadly. In terms of getting more specific on how like public experts are sort of understanding that like healthcare is maybe white-centric and colonial, could you talk a little bit more about examples of that and how that's really showing up for folks? I mean, I know some people have known that for a long time because they've lived it. Some people are getting surprised by that now. Can you talk a little more about that?
Definitely. Yeah, and I mean, I think I owe a lot of my work, first of all, on this topic to like the people, the grassroots activists in racialized communities, in Indigenous communities, Indigenous community leadership, who have been advocating for you know, the health of their people and the health of their communities for so long. But yeah, we really are seeing that, you know, public health and healthcare, which maybe you know, maybe a lot of white settler Canadians like myself see that as like, oh, just it's accessible to everyone. It's like where you go when you need help or when you're not feeling well. But really, like the reckoning with systemic racism in Canada and around the world, that that reckoning that we're in right now fully encapsulates healthcare in Canada and encapsulates like the colonial and racialized like lines that form in healthcare and in like the actual like health of communities. So in Canada, for example, one really big story I've been covering, you know, at or I won't say covering, but amplifying, is these renewed calls for Canada and BC to collect race-based data, not only on COVID infections and deaths, but also on like who is accessing relief more, who is most affected by their employment in the pandemic. And really like organizations like Migranty BC and the newly formed like Black in BC Collective and Hogan's Alley Society have been advocating for this data for so long because Canada has huge information gaps. And essentially, when you can't like quantify a problem, government and policymakers don't take seriously the fact that it exists, even when anecdotally, I don't want to say anecdotally, but like qualitatively, like people live this. So that's been I think a really big story to come out of this, is realizing just that we don't know in a aggregate way, like how people of different races are being impacted by not only by the pandemic, but by like the underlying conditions and the effects of like degraded social determinants of health up until this point.
Right.
Yeah, so I think that's one thing that the lack of data, which BC has now committed to, they're hopefully by September, Premier Horgan has asked, after years of advocacy and movements by advocates, to have a policy drafted around how this could work. So there is like a hopeful step in response there that we could see more.
And that's very much like a kind of a language issue. Also, almost, it's communities going, we can't even have the language to tell that you'll listen to in terms of people who can affect policy change, to sort of tell our stories. So yeah, that's definitely a huge piece of advocacy. So you're talking about the pandemic amplifying some of this long-standing grassroots work. Any other examples of that, or examples of communities' stories getting amplified in the pandemic, which might not have got heard in the same way prior to us being as focused on health?
Oh, that's a good one. I would say I think there's been a renewed attention to like the criminalization of mental health, and how criminal justice and mental health are, seen. That's kind of that police respond to calls for people in distress is not necessarily a given, but it's been like treated as such. And with like, I think at least five Black, Indigenous, and people of color in Canada being killed by police during wellness checks in the last few months, and like the ongoing reckoning with police violence in the United States as well, we're really questioning that and thinking about like who has access to mental health care. And the pandemic, I think, has brought a lot of that up to the surface. Like, I also did reporting on how the mental health impacts of COVID, not only the health and the economic impacts, are being disproportionately shouldered by racialized people, and by queer people, and by low-income people. And there really isn't like a difference in that distribution from other issues that we've seen the pandemic bring up. And I would say also just the fact, I think we've also been able to interrogate more openly when public health guidance is, who the public is that public health guidance is for. So when we talk about, First Nations in BC, I'll speak to that and to the reporting and connecting I've done with leaders and communities, but they have long histories and collective memories of the smallpox pandemic or epidemic, pardon me, it was an epidemic technically. And then the Spanish flu pandemic, just like a generation or two generations before the elders in communities across the province. So and those epidemics and those diseases were exacerbated by government policy and, considered a tool of colonialism, because they absolutely decimated communities. Up to 9 in 10 people were killed during smallpox, and up to 2/3 of some communities in the Okanagan and the Kootenays during smallpox. So public health guidance has not always been tailored and has actually been like antagonistic to First Nations communities and to Indigenous peoples. And so when we think about, reopening BC, potentially seeing more travel, the First Nations who have, taken precautions and banned non-essential travel into their communities aren't feeling heard. And I think that has reporting on those conversations, or lack of conversations, has really helped show that, public health guidance doesn't apply to everyone. And there is like that historical distrust in public health.
And that's such a, again, if you are living it, you know that, or you just have the feeling of, I don't really want to access this supposed care. But it's such a reframe for, again, for a lot of people who haven't been necessarily thinking about the long-term ways that, that Indigenous folks have been interfaced with the government. I mean, there's so much people going back and starting to learn this, and that's been a big, a big call lately. But it's definitely a reframe for when you think about some people thinking about a public service just being inherently helpful, and other people being like, no, this is really, really loaded, and I have to be very careful if and when I access this. And yeah, I definitely, I have my favorite person has definitely spent a lot of time in hospital, got a couple helicopter rides over to St. Paul's Hospital because things were acute. And I was having a conversation with my mom, and we were just going like, it's just been so close so many times. If there was ever any hesitation on our part to access the system, or on a care provider to provide the best possible care, likely we wouldn't have that person in our lives anymore. So it's, I mean, that's my personal kind of going like, that's how I got to get it in my brain and reorient this information as I learn how to look at the world differently. But you've got a more recent story too, because you talked about the history of, people not being able to necessarily trust and interface with government, quote unquote, care, but there's been more recent examples of that. Do you want to talk about what's happening in the ERs?
Sure. So just to preface this, we don't actually know very many details, but about, I think it was 2 weeks ago, just last Friday. So yeah, about 2.5 weeks ago, the government launched an independent investigation into reports that in multiple BC ERs, they confirmed healthcare providers were playing racist, like quote unquote, games to guess the blood alcohol content of patients, including Indigenous patients who entered the ER. So we don't know necessarily, if this was solely Indigenous patients, if it was disproportionately, Indigenous patients, but I think
not a great look, no matter which way you slice it.
Yeah, no matter what way you slice it, it's completely inappropriate for a healthcare provider, and I don't think I'm being opinionated to say that, to play a game with a patient's current physical state, but depending on the findings of the investigation, which there isn't a timeline, so we don't know when we'll know, that is playing on some very harmful and colonial stereotypes, considering the ways that alcohol has been kept from and used to harm Indigenous communities in Canada, by Canada, not by private sellers. And it's interesting because Indigenous people, there was a report by former provincial health officer Perry Kendall about 10 or 15 years ago, it wasn't too long ago, that said that basically significantly and across the board, Indigenous people just drink less than non-Indigenous Canadians. So there is, first of all, let me just say there's no truth to that you should be assuming that every Indigenous person drinks at all. But from my reporting and from a story I'm actually working on right now, it seems that, that kind of assumption, or even if you go to seek care and you're an Indigenous person and you're presenting with maybe a neurological symptom, I don't know, you have complications of diabetes maybe, or you've had a stroke, and so you're moving slowly, and your speech is more difficult than normal. To be asked how much you've had to drink by a healthcare provider completely destroys the trust you have in that person to take care of you. And not only does that decrease how well you feel being quote unquote cared for, but it actually decreases the efficacy of that care, because if you don't believe you're getting quality care, you're much less likely to follow instructions, you're much less likely to come back, and you're much less likely to feel as if you have been cared for and your issue has been resolved or improved enough for you to go home. So really, these games are not games. Like they have real and concrete impacts on patient care. And I'm so grateful to Colleen Varco and Charlotte Loppy at UBC and UVic respectively, who are experts in Indigenous health, who have been really like generous with their time and their knowledge with me on this topic. But yeah, there is like personal bias from care providers allowed to flourish in a healthcare system where there is systemic racism has real and terrible consequences.
Well, I look forward to reading that story, and I'll jump in and say as well, if anyone who's watching has any questions for Moira, we've got 10 more minutes because we keep these things short and snappy. So if you got any questions on Zoom, throw them into the chat and I'll read them out and we'll go through them. And your last of your three things, you were sort of talking about how political some aspects of health still are, but also that change is possible. I know a very big topic, particular in BC, is the opioid epidemic. Do you want to talk about the politics of that in the context of the pandemic?
Definitely.
Light. We're just throwing all the light topics at you today.
Yeah, no, and I think, there's no way to talk about the public health emergency that is the COVID pandemic without talking about the public health emergency that is the opioid crisis. And I know that a lot of people who use drugs and advocates don't like the term opioid crisis because it's not really the drugs that are the problem. It's like the policies and harm done to people who use them that are the problem. So I just want to acknowledge that, and I'll say like opioid poisoning instead. But basically, the pandemic has not only like essentially erased a lot of progress done in the last 4 years since that public health emergency was declared. I think what people are saying and what people who have been saying the same thing for a long time are seeing is that when government wants to make like broad and sweeping and very restrictive action to keep its population as healthy as possible and keep them alive, it can. And the fact that that didn't happen and hasn't happened yet for when you're thinking about a poison drug supply and people who use drugs, dying. In May, we had the deadliest month for opioid epidemics. It was 170 people who died in BC. And that was more than, I think it was early June that was reported, and that was more than the 167 who had passed away from COVID in the province over the last 3 months. So we're just seeing unprecedented levels of deaths due to poisoned opioids in BC. And advocates have said for so long that, what we need to stop people dying is safe supply that is not prescriber driven, that is essentially the way we manage alcohol and cannabis, that is like regulated and available for individual purchase and not marked up, obscenely. So I think people are seeing like all of the mass changes and reforms made in the long-term healthcare sector, where we've seen staff completely restaffed to a single site and paid a full-time wage, no matter how many hours they're getting, or getting full-time hours at a single site. That we've seen people literally staying home and completely changing their lives to stop the spread. And they're saying, well, why can't this happen for the opioid or for the poison drug crisis? And so I think that asking those questions has become seen as like much less radical, just because I think a lot of times we think that like there's a whole realm of solutions or a possibility that just kind of is like stop, like government can't do that. And with the pandemic, we've seen that government can. So now we're asking why, and I think it's a really valuable conversation that these are being treated as real possibilities and not radical, and not as radical as they've been characterized.
Yeah, it definitely is. It's shifted people's brains and what they think is we all have capacity for, which is extremely hopeful and still always has to be followed up by lots of conversations and work for sure.
And sorry, just to add one thing, but I think also the capacity for empathy, like BC has done, and Canada, I think as a whole, I mean, it's regionally different, but I think people, Dr. Henry is right in a lot of ways, that people have really shown like how committed they can be to the health of others. And, you know, I don't want to say that that's a blanket statement, but really like people have been doing this and people have responded to what we've needed to do. And I think the fact that we can rally that kind of empathy and that kind of like teamwork in a lot of ways is so important to think about when we think about what's possible in the poison drug crisis.
Yeah, very, very true. Great point. Now there's a couple questions, and I'll preface this with, if you haven't read up on a specific aspect of this, because I know the idea of the pandemic is pretty broad, you can just say, oh, I pass. So just putting that out there. But there was one question that says, why hasn't more attention been paid to those who have recovered from COVID-19 and are building immunity? Any thoughts on that?
I will say that I'm not as familiar with the science on that front, but from my own reading, there is almost nothing known about whether people are or are not immune from COVID after contracting it. You know, there is a lot of research being done on antibody testing and on, you know, if there might be like immunity or how long it might last, or if it works against other strains. But I will say, just from what I know, we don't know. And so if you have contracted COVID, or you know someone who has and they kind of feel bulletproof, there isn't necessarily science to back up that is true, the way that, you know, you get chicken pox when you're a kid and you're good for the rest of your life.
Right. Mm-hmm. I like that idea of what we do know, what we don't know, we don't know what we do know. I just, some sort of version of that on t-shirts is probably a good idea. Another question came in that said, why are BC's testing rates 9th out of the 10 provinces?
Oh, that's a good question. So this has been this is a very popular question during Dr. Henry's daily and Minister Dix's daily briefings, which are like the only constant in my life right now. And basically, BC took a much more targeted testing strategy once the curve flattened, and the curve flattened quite a bit sooner than the majority of Canadian provinces, and remains much like we remain like one of the lowest transmission provinces in Canada. So testing rates may be low, but lower per capita, yes, but they are essentially trying to only use testing resources where there is significant possibility of transmission. So through contact tracing close contacts, through, you know, there was a dental conference earlier in March where they tested everyone in their close contacts who had attended. So the widespread, and we're still seeing low positive rates. Like it's not deflating or inflating our transmission. So now that BC does have an idea where the transmission is happening and kind of those pathways, I would argue that right now there isn't a large need for you know, broad testing until you know, unless that again went out of control and we needed like a larger swath. But it went from broad to more narrow, so that resources could be used more effectively.
Makes sense. Mm-hmm. Makes me think about people testing for STIs. Maybe if someone's in a monogamous relationship, they're not testing as often as someone who isn't, or something like that. I don't know if that's analogous. I don't know if that's the same. All right,
I think that works.
We got two more questions just before we wrap up. You mentioned long-term care, and someone had a question that says, what have we learned about cluster staffing at long-term care homes versus only being allowed to work in one home?
Good question. So that was one of like the first sweeping reforms that Dr. Bonnie Henry enacted with her powers under the Public Health Act, was to limit long-term care and assisted living staff to only working at one facility. Because as we saw, Lynn Valley Care Center in North Vancouver had, I believe, 20 total fatalities, and also Canada's first fatality, and related to COVID. And it was due to a staff member that had contracted it, and that also in turn transmitted to other facilities where colleagues worked. And so with the effects on BC's long-term care homes, I think at the correct me if I'm wrong, but I think at the top we had about 23 or 24 ongoing outbreaks. I'll have to confirm that, but now we're down to like 3, so it's very much been contained. But anyways, cluster staffing is extremely effective, and we've only seen the number of outbreaks go down since that rule was enacted. And I think it's important to recognize that before, in 2001, the BC Liberal government enacted a pair of legislation. I think it was 2001 and 2003. There were kind of 2 laws that really like deregulated the sector and made room for more privatization and more care aides and other staff members working in care homes to be given like part-time hours, or to be like not really receiving as many benefits because they weren't under the provincial collective agreement anymore. So basically that fragmentation happened, and care aides had to, work 2-3 different sites to make up the hours and wages that they needed to keep, their families and themselves housed. And so now with this reform, I think we're really seeing, I don't think this is going to be able to be undone. And I think we're seeing that how much that matters for quality of care and infection control right now.
Great questions, great answers. Final question. We're jumping back to the idea of decriminalizing drugs. The question here is from Larry Neufeld, who says, why haven't the governments decriminalized illegal drugs? It would be a positive step towards fighting drug addiction, and there's evidence supporting this, and even looking at it from a purely financial perspective, rather than one of a compassionate view, it still makes sense. It would save money in the justice system and healthcare. So I guess the question is, what is your perspective on maybe why governments haven't made those moves?
Mm-hmm. Yeah, I know Larry's done his research, so I won't dispute anything in the question from a factual standpoint. I will say that decriminalizing, the recommendation has been from advocates has not been necessarily and from Dr. Bonnie Henry recommended this, I think just under 2 years ago, to decriminalize the people who use drugs. So, and there is a difference between doing that and decriminalizing all of the controlled substances, which would have to be done at the federal level by the federal cabinet under the Canadian Controlled Substances Act. So the province has really deferred on that and saying, this is a federal responsibility. We can't necessarily do that, but there are a number of steps that could be pursued at a provincial or a municipal level to decriminalize like drug use itself. And I don't really have a good answer for why that hasn't happened, but from my perspective and the interviews and work I've done, learning from like advocates for people who use drugs and people who use drugs themselves, is that drug use is still seen as a political issue and kind of a personal failing. It's not necessarily treated as a public health problem the way that scientifically it is. And even though like the current government in BC does recognize it as such and has this separate ministry and has been doing a lot of work, I'll give them credit for, on this file, I think it's very hard. Like the majority of people, I don't think see it as a public health emergency, and I think politically the will to do that is hard to find. And I think that the way that changes is hearing from people who see it the way it is and listening to us experts and basing decisions in science. So.
And that's, well, a great segue into your last point. The theme I've been hearing throughout the conversation is health is obviously more than hospitals, and people's empathy and ability to care for each other actually plays a huge part in everyone's health together. As a journalist, what do you think about the different kind of version of objectivity that a lot of early career journalists are working with, and how that impacts how we talk about health and empathy?
Yeah, that's a good question. I'm lucky that I think there, with the reckoning going on around systemic racism in media as well, and a lot of like racialized and young early career journalists are leading the way on thinking about the fact that objectivity in journalism has so often been on the side of white supremacy, of not being trauma informed, of you know, demonizing people who use drugs, and you know, upholding those kind of, I think, harmful views and non-empathetic views of a lot of people. And so I think I've been really heartened to see that the conversation in journalism is changing, and the fact that of course there are some questions that are like a matter of opinion, but I don't think there are two sides to racism or two sides to the value of human life. And so I'm really heartened to see a lot of reporting, and feeling supported in my own reporting that I think you know, treats those two statements as reality, and tries to report from a place of empathy and of anti-oppression.
Right. Beautifully said. Thank you so much for taking the time out of your busy pandemic schedule to chat. And yeah, this has been fantastic. And if you want to come back next week, everyone, thank you so much for watching. We're going to have Andrew McLeod, who will also talk about his perspective on some of the social determinants of health as well. So again, thank you from all of us at the Tyee, and we'll bid you good afternoon. Take care.
Take care. Thanks, Emma.
Bye, Moira.